Great. Thanks so much for the introduction, Jerry. I'm going to be picking up on some of the themes in the animation, and because I'm going to be talking also about avoidable deaths, which are happening far too early, and which are also reflective of policy choices that are being made. I particularly want to pick up on the idea that at the individual level, these deaths are people in our families, in our communities, in our neighborhoods, but at the wider level, they're an indication of how well we're doing as a society. So, just to give a bit of background as to how I came to this piece of research, when I started my public health specialty training in 2014-15, Glasgow was experiencing a very serious outbreak of HIV among people who inject drugs. And following on from that project, I was also involved in some work on the health needs of people who inject drugs in public places. And as part of both of those pieces of work, I was really struck by the fact that people were experiencing this constellation of adversities in terms of homelessness, problem drug use, and involvement in the criminal justice system. But it was very hard for us as a public health team to really get a grip on some of those challenges that people are experiencing and people's health needs because of how marginalized and stigmatized those experiences were. And unfortunately, those issues that we were dealing with in those two projects weren't isolated. Scotland is experiencing a number of challenges in this area for a number of years. So as you'll no doubt be aware, drug-related deaths in Scotland have been going up in recent decades and remain stubbornly high. Scotland continues to imprison people at much higher rates than comparator countries in the rest of the UK and Europe. And here's a report recently from the Mental Welfare Commission highlighting that it's still not doing very well for those people who require both mental health and substance use services. So a much wider range of issues that this work relates to. But I was also becoming conscious of maybe some of the bigger issues with the public health evidence base, and in particular the way that the data that are available to us shape what we think the problems are and how we try to address them. So many of you will be familiar with the fact that in the past our public health evidence base has tended towards the individualistic and the biomedical and lifestyle factors, partly because those data are much easier to gather. And even though we have a really good body of evidence on health inequalities according to socioeconomic position in this country, we actually know much less about health inequalities according to other aspects of social experience. And a lot of those issues are to do with the data that are easily available to us. And so I was interested in whether accessing data from other sectors outside the healthcare system could help shine a light on those wider societal forces and health inequalities. So I came to focus on these particular experiences based on that background. We wanted to look at homelessness, justice involvement, problem drug use, and severe mental illness. So each one of these experiences, we know from existing evidence, is associated with profound health inequalities. So very high rates of premature death and of poor health during people's lives. And although they appear to overlap significantly in the population, based on people's lived experience and stakeholder feedback, we've actually got very little numerical or quantitative evidence to demonstrate that's the case in the UK and to understand those patterns of overlap. The Hard Edges work done by colleagues in Herrier Watt is an honourable exception to this, but we wanted to extend that and particularly follow people up over time to look at health outcomes. But there are some real challenges in terms of health research in this area. So those life circumstances that make it very difficult for people to take part in primary research, to be recruited into studies and then to be followed up over time, inevitably that potentially creates biases in your research in terms of who you're studying over time. So some real challenges for research in this area, particularly because some of these experiences are very poorly captured in the routine healthcare data that we often rely on for public health surveillance and evidence. So I wanted to look at administrative data in particular. So for those of you who are not familiar with this term, it refers to the data that are generated as part of services delivering their everyday activities. I really like this phrase that it's the data exhaust of everyday life. It's a byproduct of all these other processes that make society tick. And the reason I was interested in administrative data is because it often has very large and comprehensive population coverage. It's often been collected in the same way over time. And in that way, it can, because it doesn't pose a burden on people to participate, you can help avoid some of those biases that you might get through primary research. And in particular, you can link records between different sectors and services to follow people up over time and look at their interactions with services. I felt like this was a way in which we could shine a light on some of these experiences. Obviously, there are challenges in using administrative data and limitations to it. It only tells you about interactions with services, so you still need to supplement it with stakeholder feedback and qualitative work in order to make sure that your data are reflecting people's lived experiences. And obviously some particular challenges because this is very sensitive data that needs to be dealt with appropriately in terms of information governance and security. So, based on that approach of using administrative data and those challenges around the evidence base, we wanted to ask, can we combine existing data sets to better understand the intersections between these different experiences, and in particular, what these intersections mean for health? So I'm going to be describing some of the results from this study, in particular looking at mortality, although we do hope to look at other health outcomes in the future. So, in terms of how we did it, I'm going to talk you through the slides, so don't worry. What we did was we worked with the NHS Greater Glasgow and Clyde Safe Haven, which is a secure virtual and physical environment for dealing with sensitive data in order to keep all these sensitive data sets confidential. And we worked with them to take a group of Glasgow City residents, so this is adults resident in the Glasgow City area, based on the CHI register. So this is a data set which is used as a proxy for the whole population because it's based on primary care registration. So it's the most comprehensive picture we have of local residents. Onto that, we layered a number of different data sets relating to the experiences of interest. So a data set from local authorities on people applying for statutory homelessness support, data from community pharmacies on people accessing opioid substitution therapy, like methadone and buprenorphine, data from the Scottish Prison Service on people incarcerated, and data from local authorities in the Health and Social Care Partnership on people receiving criminal justice social work reports, so people in contact with community justice services. And finally, we were also interested in the overlap between those experiences and psychosis. So there's evidence from the US that actually psychosis and other forms of severe mental illness overlap a lot with those other forms of social disadvantage. However, we had a feeling this wasn't the case in the UK because of the different healthcare and welfare contexts. So we wanted to test that hypothesis. So we included a clinical data set on people with psychosis. And all those data, we had them available for the Glasgow City population for 2010 to 2014, and we linked them to death registrations from the National Records of Scotland based on death certificates. So we wanted to look overall at all-cause premature mortality. So the statistical definition of that is people dying before the age of 75. But we also wanted to dig down into that and look in particular at avoidable causes of death. So this is a list of things that experts have got their heads together and said, these are things that you should not be dying from in the 21st century in the United Kingdom, either because they're preventable through the efforts of public health, or because they're treatable through timely access to good quality healthcare. So we wanted to look at those avoidable causes. Again, it's a bit of a metric of how well we're doing. And then finally, we also wanted to look at non-communicable diseases, because in the population as a whole, these account for a really large proportion of the disease burden. They're also preventable and treatable, but there's very little evidence about the burden of non-communicable diseases among people with these experiences, and in particular, people with overlapping forms of these experiences. So all these data sets were linked together for us by the Safe Haven, and they provided us with a de-identified research data set that we could work with. So, to share some of the findings, we had about 500,000 residents of Glasgow City in our cohort as a whole, and they're represented by this schematic on the right. So each square represents 1% of the population, so hopefully that should give you a feel for what this looks like. And then the paler boxes show us the people with any experience of interest and more than one. So about 5% of people in the cohort had any of these experiences. That's around 28,000 people. And 1% had more than one, about 5,000 people. When we looked at the overlaps between the different experiences, we found some really interesting findings. So I'm about to show you a bar chart where the vertical axis is the number of people with any of these experiences. Along the bottom is the experiences we're interested in, and then the bars will be divided up into the people who just had this experience on its own versus had this experience with at least one of the others. So you can see that homelessness was the most common experience of interest overall, followed by opioid dependence, prison, community justice, and psychosis is the least common. But when we look at the shading and we look at the proportion of people who had multiple versus single experiences, it varies between each of these. So for instance, thinking back about that hypothesis about psychosis, a very small proportion of people with psychosis had any of the other experiences of interest. So this does appear to be quite different from the evidence from other contexts. However, in contrast, if you look at people in prison, about 50% of them had at least one of these other experiences of interest. So really high levels of overlap with these other forms of disadvantage among people passing through the prison system. And when we looked at all the possible combinations, and I'm not going to show that diagram today because it blows your mind, it takes a long time to talk through, but homelessness opioid dependence, and involvement in the justice system were the experiences which tended to cluster together, and experiences involving psychosis were much less common. When we looked at the demographic profile of people with the different combinations of experiences, most, although not all, showed a male predominance, again, particularly for those involved in the justice system, and the majority of those affected were aged 30 to 50 years. People with these experiences, and in particular people with multiple forms of disadvantage, were more likely to live in the most deprived area of Scotland. And where ethnicity data was available, it was only available for some, but not all of our data sets, they're predominantly white Scottish and British people having these experiences. So moving on to our findings about premature mortality. So to summarize this, I'm going to show you an infographic which represents how much more likely are people affected by these experiences to die early compared to unaffected people in the rest of the population. And each stick figure on this will represent a one-fold increase in the risk of dying before the age of 75 compared to people without these experiences. So for instance, people with any one of these experiences are 4 times more likely to die prematurely before the age of 75 than people without any of these experiences. But the picture looks a bit more nuanced once we start looking at the different combinations. So as you can see, people with multiple forms of disadvantage are much, much more likely to die prematurely, even compared to those with just one form, who are in turn much more likely to die prematurely than people without. But it does vary according to different experiences involved. So for instance, people with opioid dependence, you can see that even people with just opioid dependence and none of the other experiences of interest during our study period were 7 times more likely to die prematurely, increasing to 11 times if they had other forms of disadvantage. However, it's also worth bearing in mind the scale of some of this. So for instance, for homelessness, although people with homelessness on its own about 2-fold more likely to die than the rest of the population, that's perhaps a smaller increase than some of the other data presented here. People with experience of homelessness represented almost 2% of our entire study cohort. So if you think about a 2-fold increase in premature mortality applied to 2% of the adult population, you start getting into really large absolute numbers. So summarizing next our findings on deaths from avoidable causes and non-communicable diseases. So for not avoidable causes of death, so things that we shouldn't be dying from if our healthcare system and public health systems are working well, again, very similar findings to what we saw for premature mortality. Extremely high among people with multiple forms of disadvantage, and also very high among people with just one form of disadvantage. Around 80% of people, causes of death among people with multiple forms of disadvantage were considered avoidable. And it was particularly the preventable forms of death that were especially prominent. And I think that's a real interesting challenge to us as a public health system about who our efforts aren't reaching. And I think it perhaps counters some of the fatalism that you sometimes encounter in terms of these forms of disadvantage and the mortality burden. 80% of the deaths that we saw were from causes we are considered avoidable. Similarly, for non-communicable diseases, we also saw, interestingly, that the mortality burden from non-communicable diseases was higher among people with multiple forms of disadvantage. And this was really interesting because in the evidence to date, as I said, we found very little on non-communicable diseases. And we also know this is an area which services aren't really, not necessarily on their radar. And so that neglect, perhaps, of non-communicable diseases in the past doesn't seem to be because they don't affect this population. We saw really substantial rates of non-communicable disease. Although they accounted for a smaller proportion of deaths than people in the rest of the population, because people are dying at such high rates, the absolute burden of non-communicable disease deaths in this cohort was really high. So what does it all mean? So although this is quite descriptive work, it just tells us how things is and doesn't necessarily tell us how to change them, I think that having good descriptive data about what these intersections look like and what the mortality burden is can help inform our services. So to give an example of that, if we know where the intersections are, we perhaps know better which services need to be working together to deal with these overlapping experiences and to address them. Similarly, that example of non-communicable diseases, I think that's a real challenge for the services who are in contact with people with these experiences about what we're doing in terms of prevention and treatment of non-communicable diseases in those settings. And in terms of how we respond, these are complex issues, and no one single thing will make a difference. We need action at multiple levels and across multiple different policy sectors. So I've borrowed this framework from, it was Health Scotland, now Public Health Scotland, about how we'd address health inequalities. So we can work to mitigate these health inequalities through our healthcare services by better meeting the health needs associated with these experiences. But we can also go one step upstream. We also need to be preventing the health impacts of these experiences, for instance, by rapidly resolving these experiences when they do occur. And then we also need to be thinking about the next level upstream, and how do we undo these health inequalities? How do we address the fundamental causes that drive these experiences and avoid them happening in the first place? And that speaks to the need to prevent a lot of the underlying drivers of these experiences, such as poverty, particularly in childhood, other forms of childhood adversity, and some of the features of our housing markets, our employment markets, our justice system, how we deal with problem drug use, that create and maintain these processes of exclusion. And we also do need to move beyond description. So this study is very much intended as a proof of principle, showing we can link these data sets. And now we've done that, how can we use that to better understand what works to solve these challenges? And it gives us the opportunity that if a new social policy comes along, hopefully we can use these data sets to evaluate what its health impacts might be. So that might be a change in sentencing policy, or a change in sanctions for drug use, or perhaps a change in homelessness entitlements. It allows us to look at what the knock-on impacts, health impacts of that might be. But to do that, we do need changes in the way we do this sort of cross-sectoral data linkage. This wasn't easy. It took a lot of time, and there were times we didn't think it was going to happen. And so if we're to do those kinds of evaluation, if we're actually able to harness the potential of this kind of cross-sectoral data, we do need a much more agile and responsive approach to linking data, and ideally to doing it on a routine basis, not on slow academic timescales like this, so that we can use it for the purposes of public health surveillance. So I'm just going to finish up by saying a big thank you to all the people whose data we used in this research, collected by NHS, local authorities, and the prison service as part of their care and support. And also to my funder, the Chief Scientist's Office, and to the Social and Public Health Sciences Unit, to the project team, in particular Vital, Alistair and David, and finally to our stakeholder advisory group and public engagement participants who helped us make sense of the data. Thanks very much for listening. I'm really looking forward to Q&A.